All right. So thank you very much for joining. I'm looking at the numbers of participants that are logging in. So I'm gonna wait 1 more minute so we can give everybody the opportunity to log in, and I will introduce Dr. Myers, and we will start the seminar. Well, I think the numbers have stabilized, so I think we're gonna start. So it is my very pleasure to introduce Dr. Kenneth Myers. I printed the bio, although I know him from many years ago, but I don't want to make mistakes. So Dr. Myers has been a pediatric epileptologist, a clinician, and scientist at the Montreal Children's Hospital since 2017. Um, After completing an MD and PhD in pediatric in medicine and pediatric neurology residency here in Calgary, and that's where we met. He moved to Melbourne right after and did in Australia a couple of years of epilepsy fellowship with a special focus on genetics. It's quite a big center and very well done fellowship, very productive since younger. His current research is largely focused on epilepsy genetics and rare disease clinical trials, and that's what he's gonna try to convey today, particularly with the genetic part. So he will be talking about epilepsy syndromes involving seizures triggered by fever, or epilepsy syndromes with febrile seizures. So Dr. Myers, thank you very much. You could start sharing the slides, and thank you, Kathy, for joining us. I'm seeing you here. Okay, I'm gonna allow you to share the slides, and can you can you do it?
Sorry,
Yep. I just let
one
you
second.
share. Yeah.
Uh,
Yeah. Yeah. No problem.
all right.
Yeah. So
So everybody can see my slides, I hope.
yes, we can see it in presentation mode, and we can hear you well. So the floor is yours. Thank you.
Okay. Excellent. Thanks very much, JP. Yeah, I'm very excited to give this talk. Fair bit to go through, so I'll just jump in. Um, First off, these are my disclosures. I think the only one that's probably relevant for today is that I did receive a small research grant from Dravet Canada a few years ago. Um, Okay. So learning objectives by the end of this session, I'm hoping everybody will be able to describe the clinical features of Dravet syndrome, PCDH19, clustering epilepsy, febrile seizures plus, fires, and HHE. So I modified this a little bit, so something different may have gone out earlier, and to describe a management plan for patients with Dravet, PCDH19, and FS plus. So, jump in starting with febrile seizures, because I think it's important to review exactly how these are sort of defined. This is from a 2009 um, document. So it, has to be a seizure in the context of fever, can't be an acute disease of the nervous system. So, meningitis couldn't be a cause for febrile seizures. You don't need to have a fever documented prior to the seizure, but it has to be there kind of immediately post-ictally. Fever is defined as 38 degrees Celsius or greater, and the usual age range for febrile seizures is 6 months to 6 years. Um, so, gonna just pause for a second. Apologies to anyone who's worked with me as a trainee that's probably heard this before. But I just want to quickly talk about simple versus complex febrile seizures. So, the way I sort of remember what the definition of a complex febrile seizure is sort of the three Fs. So frequency, if you have recurrence within 24 hours, 15, so lasting 15 minutes or longer, or having focal signs. And then some people also consider complex if there's neurodevelopmental deficits pre-existing or if they have afebrile seizures. Um, so I really don't like this definition, and I'll try to explain why. Um, so we go through three scenarios, and just to reiterate, you just need to have one of these three Fs to be a complex febrile seizure. So if we go through three scenarios, so the first is an 18-month-old, previously normal boy. In the past 24 hours has had two bilateral tonic-clonic convulsions lasting about 30 seconds. He has a fever and clear URTI symptoms, and there's a positive family history of febrile seizures. So when we get these calls from the ER, it's generally good that they're by phone and not in person because we're usually not pretty, overly excited about them, and not particularly concerned about the patient, even though for sure for the families these are very, very scary and they need, appropriate counseling. Um, Second scenario, if we have a 2-year-old typically developing girl who has a bilateral tonic-clonic convulsion at daycare, and the daycare workers say it lasted 16 minutes, so that would get her complex by the duration. She also has fever and URTI symptoms, now back to normal. Um, Maybe a little bit more interested in this one, but wouldn't say I'm especially concerned either. That duration may not be accurate anyway. And even if it was, like we had data on prolonged febrile seizures, and these patients generally do quite well. Um, and then a third scenario. So if we have a 14-month-old, previously well boy, who's come in with a 3-minute hemiclonic seizure, so focal, in the context of a fever, and he doesn't really have any signs of being sick, clearly, other than the fever. So when I get these calls, I'm quite a bit more concerned, because maybe this will turn out to be a febrile seizure, but we really need to be thinking about like, you know, meningitis, abscess, cerebral venous thrombosis. There's a lot of things that could give you this that need specific treatment. So these are patients I really want to see right away and probably do some investigations. So why does it bother me so much, the complex febrile seizure? It's because we get referrals like this, where it just says complex febrile seizure, and I really have no idea how concerned I should be. Should I be rushing to see the patient, or should I be essentially redirecting it to a pediatrician? Okay, rant over. So we'll now move into the epilepsy syndromes with fever-associated seizures. So I'm going to start off with FS plus, but we'll also touch on GEFS plus. Um, so I find this is something that a lot of people get wrong or confused about. So febrile seizures plus is an epilepsy syndrome where patients basically have to have one of these two things, either bilateral tonic-clonic convulsions with fever that occur outside of the usual age range for febrile seizures. So rarely is it before 6 months. Usually it's patients having febrile seizures after 6 years, or if they've had febrile and afebrile bilateral tonic-clonic convulsions. So you could have a 18-month-old who's had a febrile bilateral tonic-clonic convulsion, and if they come back at 2 years with an afebrile bilateral tonic-clonic convulsion, you can already diagnose them with FS plus at that point. And this is from the ILA 22 classification. So FS plus, these patients generally do quite well. Their development is usually normal. Sometimes they will develop other seizure types. In this case, you would usually write their diagnosis as FS plus for absences or FS plus myoclonic seizures, whatever their other seizure type is. Sorry for my dog. Um, Usually they're pretty easy to control. You may not even need to put them on a maintenance anti-seizure medication. If they particularly, if they've only had one afebrile seizure. Um, and then the seizures usually spontaneously resolve. And it is important to know that these can occur in the context of GEFS plus, which is something different, however. So what is GEFS plus? So this is a familial syndrome, which means you can't you can't say that one person has GEFS plus. You should be referring to a family when you talk about GEFS plus. And in these families, multiple people have seizures, and they can have different phenotypes. The most common phenotypes are febrile seizures or febrile seizures plus. Um, but you can have phenotypes within these families where the individual has not had seizures with fever. Um, Obviously, these are thought to be genetic, but genetic testing is negative in the really the vast majority. There's been a number of genes associated with GEFS plus. There is a longer list that I haven't put here. The main two where it's sort of pretty convincing from multiple families, I would say are SCN1A and SCN1B. For the other genes, it's less clear, and usually the data are just from one family. Um, but at least those other genes probably contribute some risk. So this is kind of what GEPS plus families look like. Over here on the left, family K, we see that they have a couple of people with just straightforward febrile seizures, a couple individuals with epilepsy with myoclonic-atonic seizures. In the middle here, we have a bunch of people with unclassified seizures, so presumably history taking was difficult. Um, but we do have an individual with epilepsy with myoclonic seizures who's had three children, two of whom have FS plus, and one of whom has Dravet syndrome. So in this family, you would think probably a good chance that they have STN1A. And maybe I'll just leave it at that. Um, this is just sort of to reiterate the phenotypes that you may see in GEFS plus families. The FS and FS plus are making up the vast majority, but there are a lot of other things you can see that may be focal or generalized. So this sort of leads into Dravet syndrome because Dravet syndrome can happen in GEFS plus families, although it is fairly uncommon, only about 3% from this one study. Um, so Dravet syndrome is an infantile onset DEE. Um, the exact percentage that are caused by SCN1A pathogenic variants varies a bit study to study. I think it's almost 100% if you really know what you're doing in terms of diagnosing Dravet syndrome. But I think 90% is probably a reasonable number. It is a rare disease, but not so rare. So if you're working in an academic center as a pediatric neurologist, you should be seeing this um, as part of your practice. In terms of the seizures in Dravet syndrome, so they usually start around age 6 months, and almost always the initial seizures are with fever, and they're usually presenting with a febrile status epilepticus. Now, the really classical presentation is an alternating hemiclonic febrile status, and by that I mean that they come in one day and they have a right-sided hemiclonic febrile status, and then maybe 3 weeks later they come back, and this time they have a left-sided febrile hemiclonic status. Um, if you do get that story, it's almost certainly Dravet syndrome, but you do not get that in all Dravet patients. Um, and then later on, these individuals will start to develop afebrile seizures. There are a lot of different seizure semiologies they can get, but the most common are generalized tonic-clonic, myoclonic, absence, and focal impaired consciousness. In terms of the EEG, it should be normal initially. Um, if you're doing the EEG, right after they've had status, you may see slowing. But it's actually quite important, the initial normalcy of Dravet syndrome, and this sometimes confuses people, which we'll get to. Um, by 2 years, you're going to start to see abnormalities on the EEG. There's not a really classical pattern. They usually eventually have some background slowing, and they'll have epileptiform discharges, but they may be multifocal, generalized, or both. In terms of development, development is generally normal to age 12 months. And this actually makes it a bit challenging when you see these individuals in the first year. and make the diagnosis either, well, clinically and usually later with an SCN1A mutation identification. Because a lot of the parents, when you tell them that their child has Dravet syndrome, they'll go look it up and they'll say you're way off base. Like, I read about Dravet syndrome. I saw severely intellectually disabled people. My child's completely normal, so you're wrong. Um, and in those situations, you kind of have to say, well, I do hope I'm wrong, but um, again, if you know what you're doing, almost always you'll make the diagnosis and you'll start to see development regress or plateau in the second year of life. There is actually quite a big range of long-term developmental outcomes, though. Um, all these patients are going to have some degree of intellectual disability, but I am aware of at least one person with Dravet syndrome who got married. Some for sure do have severe ID, but some do actually fairly well. There are a lot of comorbidities that come along with Dravet syndrome, and sometimes seizures are actually not the biggest problem for families. Sleep disturbance is a very big one in some cases. So about three-quarters have some form of sleep disturbance. It can be either problems with sleep initiation or maintenance, or often both. I did do a study during my fellowship um, that found that melatonin could be quite beneficial for at least some patients. Um, Feeding is also a big problem for some patients with Dravet syndrome. Some are very fussy. I follow one boy who basically will only eat poutine, and it's incredibly frustrating and stressful for families. We did this study past couple of years and found particular patterns of food preference scores, and also that these patients are very slow in eating. Um, in the UK, there's actually quite a large percentage of patients that end up with G tubes. It's in contrast very low, at least has been my experience in Canada and also in Australia. I think it's probably just a bit of different practice. I'm not sure what is better or worse, but that could be something to consider if you have really, really big feeding problems. Um, so this is Crouch Gate. This is a video from Professor Scheffer. Um, so Crouch Gate is something that tends to develop in adolescence. You see this guy's knees are bent as he's walking. He's also a little bit up on his toes. Despite that, actually functionally quite good. See here, he's riding a three-wheeled bicycle. He's got decent coordination to hit this ball, he will hit it. um, some sort of play games, and then at the bottom there you see him like hopping over this bench and actually like jumping off. Um, which if this was like a really hectic gait, probably wouldn't be able to do things like that. So these patients don't actually tend to fall that much, but they can be very slow in getting around because of this. Um, Another thing I think to be aware of when these patients are coming in with status is that for reasons we don't really understand, they seem to be at increased risk to develop cerebral edema after their status. This is from a case series of patients who unfortunately developed cerebral edema and subsequently died as a result. So these images we see this patient when they initially presented. And really all we see is some restricted diffusion in kind of the pericentral area, but it evolves over the next few days to this malignant cerebral edema that ultimately led to their death. And we see that it's evolved to vasogenic edema on the diffusion sequences at the bottom right. So this kind of leads into mortality, which is unfortunately quite high in Dravet syndrome for multiple reasons. We've discussed some of them already, but SUDEP is still the most common cause of death here. You see there that the risk for SUDEP is about 15 times higher in Dravet syndrome than other childhood onset epilepsies. So this is something, again, causes a lot of stress for families, particularly when they're not able to have their child's seizures controlled. So this is the ILAE Dravet syndrome criteria that were recently published. So I don't want to go through the whole thing. I do want to highlight up in the top right that there is an early infantile SCN1A DEE that usually comes along with contractures. And I've had some issues with people misdiagnosing these patients as having Dravet syndrome. So these patients will not have a normal EEG usually at the time of diagnosis. Their development will never be normal. They are much more severe than Dravet syndrome. And so they don't have Dravet syndrome. And this is even, it was enough of a problem that the ILE um, put it into their criteria as an exclusionary criterion. I'll leave everything else sort of alone here. Um, in terms of treatment for Dravet syndrome, I find actually my Dravet patients are doing pretty well overall, and I think it's because I, I like to think that I get them diagnosed fairly early and get them on sort of the right medications, and then they seem to do relatively well. So the kind of classical three medications, and usually they'll be on all three of these, are valproic acid, clobazam, and stiripentol. Topiramate is often very effective for these patients as well. Um, and then we generally try to avoid sodium channel inhibitors because they can make these patients worse in some cases. Um, it's a bit of a side note. There is a small subset of Dravet patients that, for reasons we don't understand, respond extremely well to sodium channel inhibitors. These were patients were just sort of identified because sort of what would happen is they would present with, focal status, and somebody would sort of not think about Dravet syndrome and put them on carbamazepine. Um, a few months later, they'd see a neurologist and who would recognize that they had Dravet and think, oh my God, we've got to get you off carbamazepine. Their seizures would then worsen. Parents would ask to go back on carbamazepine. They'd do well again. So this is a minority, but I'm just mentioning it because it can happen. It is still definitely best practice to avoid using these medications, though. Um, there are some newer agents now available. I won't go into them in too much detail. Fenfluramine you can get in Canada. It sometimes can be a lot of paperwork, but there are data for it being fairly effective for seizures in Dravet syndrome. Similarly, cannabidiol um, has some good data from randomized control trials now. Um, I'm going to briefly touch on what's at least very exciting for people interested in Dravet syndrome, including obviously the patients and the families, that there are some now therapies in development and I think hopefully quite close to being available that more directly target the molecular problem rather than really just trying to control seizures. So this is an antisense oligonucleotide. Again, I don't have that much time, so I won't go into it in detail. But basically, a person with Dravet syndrome is going to have two copies of the SCN1A gene. The copy in red has mutation, so is basically not functional. But the good copy has different mRNA transcripts coming off. Um, one of the transcripts will make functional protein, which is good, it's what they need. Um, but there's an alternate transcript that usually just gets degraded. And so with one of the ASO therapies, the idea is that the ASO will bind to this alternate transcript and then allow a functional protein to be made. And this will then sort of increase the amount of functional SCN1A protein. So we're going to move on and talk about PCDH19. So I think this is another one that once you start to know about it and think about it, you can pick these patients out. And I think the last two or three patients that have presented in Montreal, I've been able to clinically diagnose them before any genetic testing was done. Um, When I was in training, I remember being told that PCADH19 was sort of Dravet syndrome that only girls get, but that's really not the case. Um, I'll get into the differences. So PCH19 is a gene that's on the X chromosome. It encodes a protein called protocadherin 19. Um, that is sort of a membrane-bound protein that does multiple things. Um, PCH19 epilepsy usually starts in infancy. Mean age is 10 months, but there's a bit of a range there. It's almost exclusively females affected. Um, but unlike Dravet syndrome, although these patients tend to present, in infancy with febrile seizure, with seizures in the context of febrile illnesses, um, Dravet syndrome, patients with Dravet syndrome will have really like a prolonged convulsive seizure that lasts, 30 minutes or longer. Whereas the patients with PCDH19 have these clusters of shorter seizures. And these clusters can last sometimes several days, but they're not having individually prolonged seizures. Um, their seizures are usually focal with motor onset. So this is a patient that followed here in Montreal. So we see her starting to have a seizure now. It's a focal seizure. She had an unusual presentation. If you look at, and you can see the clinical signs of the seizure. If you look at the ECG, her heart has stopped beating. Um, and that basically, I believe, lasted about 12 seconds. Um, and the seizure goes on, her heart starts beating again. Um, and seizure will eventually end. It's not long. It was so seizure was in. So I don't know the whole thing. Just um, asystole is not a common thing in PCH19. We published that just as a case report. Um, so it's just sort of an interesting aside. Um, In terms of the prognosis of PCH19, seizure frequency tends to decrease after the first decade. Some patients have spontaneous remission. Um, most patients have some degree of neuropsychiatric abnormality. About a third are diagnosed with autism, about a quarter have obsessive compulsive behaviors, um, but about a fifth will have average intellect. So it is not so uncommon to have a patient with PCH19 and then find that their mother actually also carries the mutation and may have had a history of seizures in childhood. In terms of the treatment for these patients, there's not a clear anti-seizure medications that's better or worse. When we have these patients coming in, though, I think it's really important to remember the natural history because usually when they come in with their clusters, they're having a lot of seizures and almost nothing is really very helpful. Um, but once you know what they have, you know that they're going to have this cluster of seizures and that the seizures are going to be short and that it's going to stop on its own in a few days. So you should really try to avoid over treating. So when these patients come in, like sometimes I have to call emerge to say, don't load them with phenobarb or start a midaz infusion to the point where they're going to need to be intubated because um, probably not in their best interests. They should probably stay in a hospital and be monitored, and within reason, we'll do what we can to try to control the seizures. But we don't want to take it too far. And I've even had, ICU doctors saying, well, nothing's worked for the first day or two. Maybe we should just withdraw care. And it's like, well, no, that's crazy. Like this person's going to get better. Um, and similarly, I try to avoid, because they'll go weeks or months without seizures between the clusters, I try to avoid adding on a whole bunch of medication when they come in acutely and then leaving them on it until the next cluster happens because they probably don't actually need to have that much medication between the clusters. Um, and they should, I think, still be on something. But but you don't want them having a bunch of side effects from medications in between their clusters if they don't need to. Um, People have looked at trying to have a sort of more specific treatment for PCH19. There's this trial that was done for ganaxolone, um, and basically they looked at 28-day change in seizure frequency, which I'm not sure if it was the best outcome measure, just given that these patients have clusters of seizures where, they may have 50 in a 2-day cluster, but then not have anything for a month or two. But anyway, I'll set that aside. Um, um, Unfortunately, this was a multi-center study, 20 sites across 7 countries. Despite that, their target enrollment was 70. They were only able to, in the end, randomize and follow to completion 20. Um, Despite the low numbers, they actually had fairly exciting, at least trend of improvement in the ganaxolone group versus the placebo. Unfortunately, this was not still statistically significant. Um, and again, maybe it would have been if they'd been able to reach their target recruitment, or if they'd used a different outcome measure. I'm actually getting near the end a little faster than I thought. Um, So I see that there's things coming up in the chat, so there should be lots of time for questions. So just before we end, I'm going to touch a little more briefly on first FIRES. So this is febrile infection-related epilepsy syndrome. So this is a subset of new onset refractory status epilepticus. Um, the 2022 ILE epilepsy classification mentioned it, but from at least what I could tell, that they don't give a specific diagnostic criteria. Um, from the other publications, the general requirement is that you should have had a febrile illness in the 24 hours to 2 weeks prior to presentation with status epilepticus. Patients are generally having focal or multifocal seizures, and it's often divided into an acute phase, which is basically the initial sort of status epilepticus, and then the chronic phase, where these patients continue to have epilepsy. They're a bit more stable, but often still difficult to control. And some of these patients will recur with clusters of seizures every few weeks. Um, in terms of imaging, so brain MRI is usually normal in these patients, at least acutely, but they may develop some diffuse atrophy over time. On EEG, you will usually see some degree of slowing that may be focal, multifocal, or generalized. Um, and also, you'll see interictal epileptiform discharges. But similarly, they can be focal, multifocal, or generalized. And then the last thing I'm going to touch on is hemiconvulsion hemiplegia epilepsy. This is a fairly rare entity, but again, it is important to be able to kind of recognize because and understand a bit. Um, so in these patients, they generally present with focal status epilepticus, usually motor, in the context of a febrile illness. They're usually previously well children developmentally normal before that. Once they get through this acute phase, they will develop a hemiparesis, and then usually also have an ongoing chronic epilepsy. So this is the MRI of a patient with HHE in the acute phase. So on the left, we see this restricted diffusion in the left posterior region that looks like a stroke. These patients sometimes or often get diagnosed as having strokes. And then on T2, we see signs of edema in that same region. A few months later, this is what the patient's MRI looks like. So you see this really dramatic atrophy that has developed in the left hemisphere. Um, And so I mentioned that these patients evolve into chronic epilepsy. They can sometimes evolve into this sort of interesting Hemi-Lennox-Gastaut pattern. So here we see the interictal abnormalities of the patient, and this was like, I think, a year or two after their initial presentation. Um, so on the right, we see I would call this PFA. There's a kind of a big sharp wave before. Um, it is we see it bilaterally, but it's certainly more prominent on the right. Um, and then we also see slow spike wave over here, more kind of right temporal. Maybe maybe it goes a little bit on the left, but it's certainly more prominent on the right. Um, Now, this is interesting because if we go back to the MRI, it's the left hemisphere that was affected. Um, but here we're seeing abnormalities mainly on the right. And I did check with the EEG techs to confirm electrode placement was correct, and they got very mad at me and insulted. But the electrodes were correctly placed. And then the patient even had tonic seizures. This is the ictal pattern, which again, more you do see it bilaterally, but certainly higher amplitude on the right. So they have basically evolved into like a Lennox-Gastaut syndrome that's mainly just in their right hemisphere. But interestingly, that's what appeared to be healthy on the MRI. So in this patient, we actually did a hemispherectomy of the left, and then they got much, much better um, clinically. So I put a little, I like to put quizzes at the end of my presentation. Obviously, I'm not going to put anybody on the spot here. If you feel like typing answers into the chat, feel free to. Um, but this is just to sort of help things kind of stick. Um, so Um, First is a case. So I have an 18-month-old girl who has a 20-minute left-sided hemiclonic seizure at age 7 months. It occurred after a vaccination, and she had a fever. After that, she's had four more prolonged seizures, three in the context of febrile illnesses, but one was afebrile. Um, and her development was normal, but parents have recently noted that she's started to plateau. So pathogenic variant in what gene is most likely? Um, few seconds to think about it. Um, but most likely this is SCN1A. And then I think we could basically already diagnose her clinically with Dravet syndrome. Um, so next, a 4-year-old boy has a history of three febrile bilateral tonic-clonic seizures. They occurred between the ages of 18 months and 36 months. But now at age 4 years, he's come in with a 2-minute afebrile bilateral tonic-clonic seizure. He's got normal development. So what epilepsy syndrome does he have? I'll just give a few seconds for people to put things in the chat. Unfortunately, I can't see the chat while I'm doing it. So he has febrile seizures plus because he has had now febrile and afebrile bilateral tonic-clonic seizures. Um, so next, this same boy has a family history of a father with febrile seizures, and his sister has childhood absence epilepsy. So what familial syndrome is going on here? So this is GEFS plus, so genetic epilepsy with febrile seizures plus. And okay, I think we have one, maybe the last one. So we have a 2-year-old girl with recurrent febrile status epilepticus. When we try to clarify that, turns out she's had three admissions to hospital, each lasting 2 to 3 days. And each time she's had 20 to 30 focal seizures, and she's always had a febrile illness. So pathogenic variant in what gene is most likely responsible? So this sounds very much like PCDH19. So that's all I have. I'll stop sharing and yeah, we should actually have a fair bit of time for questions.
Wow, excellent. Thank you so very much for a very nice overview of seizure triggered by fever and genetic etiology. So